And welcome, everybody. We really appreciate you taking an hour out of your day today for what I'm sure will be a great conversation with leaders from Mackenzie Health, which earlier this year opened the first smart hospital in Canada, supported by a number of technology vendors, including Get Well Network. We're so honored to play a key role in supporting the patients and families that you care for, and also the clinicians who serve all of them. So thank you, panelists, as well, for your time today. I'm Nakia Bergan, president of Get Well Network, and I'm joined today by three exceptional panelists representing Mackenzie Health. First, we have Altaf Steshamwala, president and CEO of Mackenzie Health, a role he's held since 2010. Under his leadership, Mackenzie Health has been recognized numerous times for its commitment to safety and quality patient care, recognition that helped gain approval to build the organization's second hospital, Cortellucci Vaughan Hospital. We're also joined by Richard Tam, Executive Vice President and Chief Administrative Officer at Mackenzie Health. Richard is responsible for numerous portfolios at Mackenzie, including automation and technology, and transformation and innovation. And finally, we have Dr. Aviv Gladman, Chief Information Officer and Chief Medical Information Officer at Mackenzie Health. Dr. Gladman is a critical care physician and licensed electrical and medical engineer, and is an expert in intelligent workflow automation and disruptive change, things that for sure we know were instrumental in the design and build of Cortellucci Vaughan. So we're here today to discuss the inspiration behind the project and explore what drove Mackenzie Health to design a fully integrated smart hospital. We'll share some best practices and lessons learned, and hear how, when the hospital first opened in February of this year, it actually did so as a facility helping offset capacity concerns stemming from COVID-19. As Tanya mentioned, we'll save time for Q&A at the end of the discussion. Please feel free to use the question chat feature in order to submit those throughout. So Altaf, let's start with you. Would you start off by telling us today a little bit about Mackenzie Health and the community you serve?
So thank you, Nakia, and thank you for having the Mackenzie Health team here. Mackenzie Health is located in the Greater Toronto area. We service three main suburbs of Toronto, Richmond Hill, Vaughan, and King, a population of about 650,000 residents, and in the past really served by one hospital, at that time, the Mackenzie Richmond Hill Hospital. We're defined by a high growth sort of suburb, really driven by the fact that we now have public transit and subways into our community that is driving high density growth, along with obviously the nature of an aging population. So we have recently added a second hospital to our network, and obviously that more or less doubles us in size. So we are approaching about 800 beds across our sites, everything from long-term care to non-acute care beds to acute care beds, so the full spectrum of service delivery. We also have 6 community-based locations throughout the region. So again, a growing organization, one that's had the benefit of investing in new facilities and technology, and we're happy to share some of our journey with you today.
Thank you. So we know that you built the first smart hospital in Canada, but before that, Mackenzie Health was already being recognized for its investment in and use of technology. As you began plans for a second hospital, what drove your decision to build that as a fully integrated smart hospital?
Yeah, I would argue that our efforts around adopting technology really was driven by the fact that in early 2010, 2011, we were an organization that was challenged from a fiscal perspective. We tried to really drive efficiencies in our organization, at the same time improving our quality and our patient experience, and really became very much driven by lean philosophy. And whenever we had a lean event, we always engaged the staff to say, so if we could bring in a new facility and design it differently, and if we could bring in technology, what would we do differently? So a lot of the nuggets of power that came behind the smart vision really did come from our frontline staff in those episodes. So high degree of staff engagement, and then and there we knew, under Richard's leadership and Aviv's leadership, that we would never stop engaging our frontline staff as we looked at technology as a way to drive safer and more sort of efficient care. I think the biggest effort really came about when we became Canada's first end-to-end Epic hospital. So that EMR adoption and our ability to really use that as the backbone that would drive sort of integrated technology-driven care really came about as, I think, a foundation point about 4.5 years ago, and we quickly moved from being an MRAM 6 to an MRAM 7 hospital. So we're the only acute care hospital in Canada that's achieved that MRAM 7 designation. So with that as the backbone, I think, with the investment in a new building, the existing Mackenzie Richmond Hill Hospital had its limitations, the very nature of the building automation system, and how much you could put in there. Having a greenfield building gave us that opportunity. So we really heavily invested in core infrastructure. I think that started to drive the foundation of a smart hospital. So our real-time locating system, I think, and Richard will speak more to that, the investment that we made in that upfront, our ability to look at a whole bunch of other devices and how they would be integrated, and sort of that interfacing of devices from beds to infusion pumps to you name it, and all again being connected to the electronic medical record. And then obviously the fact that with a brand new facility came much more sophisticated building automation systems that could also kind of be integrated. So that's really the foundation. We want to ensure both our hospitals have some degree of equity and equality in terms of the smart workflows, but obviously with a new building comes additional opportunities, but very much driven by the basics of how do we become leaner, how do we become really driven by the values of mitigating risk and high quality, and ensuring that the patient experience is always forefront, which is sort of where Get Well came into the equation as well.
Excellent. Thank you so much. Picking up where Altaf left off, Richard, obviously for all of its promises, integrating smart technology throughout a hospital setting is obviously also not without its challenges. And we'd love to hear a little bit more about kind of the approach you took for this project. It might be helpful to give just an overview of the types of technology that you have used throughout the organization and just your overall goals for the undertaking.
Sure, happy to. I just want to build on what Altaf was saying, right? Really, the approach is a very humble beginning. We actually started a lot of the design, a lot of the investment and testing of the smart technology, actually not waiting for the new hospital. It was actually 9 years ago when we actually got the mandates to build a second hospital. We started thinking that we cannot do the same thing again. And by the time, as you say, like open the hospital, then it will be obsolete. So we want to inject some of the technology and innovation in the existing current hospital in Richmond Hill back then. And we actually started to, as Altaf said, engage a lot of staff and finding real life problem statement that they actually tell us, the user tell us. And then we inject the technology accordingly to create a value proposition to make their life easier. And basic stuff like even using cardboard, typical like lean Kaizen events to drive the ideal state. And only after that, we started to introduce or layer the technology as a solution, already have a problem, rather than injecting technology and still looking around, where's the problem and what is the value proposition. And that took a little bit of time. I'm not going to lie about that. It took slower kind of beginning, but much faster adoption. And that's why way before Mackenzie actually have the second site built, we already been recognized by a lot of the investment in technology, the way that we use the technology, and Mackenzie Richmond Hill Hospital, such as the Chime Most Wide Award. We actually won it 2 times in a row in the past couple of years. We won the HIMSS Davis Award for the quality improvement adopting technology usage, as well as the 3M Award, just to name a few. And that actually is really how we learn and take notes and actually scale the design and the methodology to the entire Mackenzie Vaughan 1.2 million square feet design. And that's really the approach that we use. Is a very humble beginning, but we gradually scale and grow bigger. And the goal is really twofold. One is to actually improve patient experience through their eyes. We design it through their eyes, and we want to know that how do we know we actually get there? Through the feedback from the patient. The second component, equally important, we kind of want to have a dual win-win situation where it's also the provider need to have a better experience. We have to make their life easier so that they have more time returning to the bedside and taking care of patient and do what they love to do.
Excellent. Thank you so much. Does anybody want to add to that before I turn to the next question? Dr. Gladman, the past year has certainly seen a huge increase in the interest in, investment in, and utilization of all sorts of digital health modalities. What was the biggest shift that you've seen in your own community, in your own facilities regarding adoption or implementation of digital health technology? Did that movement make it easier or harder to get the teams to adopt certain new technologies?
Yeah, so I think the obviously the big one that I think everybody got used to in their own lives as well was really the shift towards a virtual environment. And I would say that healthcare in particular, although virtual care had already started to a certain extent, it certainly accelerated tremendously because of the pandemic. And a lot of organizations, I suspect, struggled to kind of fill that gap as quickly as possible. We were fortunately very well positioned because, you know, when we designed the smart hospital, the goal wasn't actually to just create a physical building with physical walls and inside everything was, you know, automated and connected. The goal was actually to build that hospital without walls. And so it was fairly easy to pivot, which I guess is a word everyone is no longer willing to hear, but to pivot and start deploying technology outside of the hospital as well. In fact, I think our greatest success through the pandemic was in virtualizing our COVID management center or COVID clinic, or rather our acute respiratory clinic or ARC clinic, which is what we called it, because it really provided an opportunity to test out a lot of the smart technology that we talked about for inside the hospital, but do it at a distance. So probably the biggest change that we saw was trying to deliver care to what would traditionally have been acute care patients that were admitted to hospital, like inpatients, and instead deliver the same care to them outside of the hospital in their own homes. And I think that was a huge change, certainly in the way that a lot of the clinicians approach things. We weren't used to, you know, like managing patients' oxygen levels and, you know, heart rates, et cetera, from the computer to inside their home, and certainly not so comfortable with having oxygen delivery on demand, of providing advice and you know, considerations of getting people into hospital for assessments, of delivering medications that traditionally would not have been given inside the hospital. Sorry, not have been given outside the hospital, rather, but doing it in people's homes. And really that was all the result of applying technology that, again, had been implemented for exactly this purpose inside the hospital, but adding that extra layer of delivering it right into the home.
Nikki, if I could add, one of the things that gives us, I think, a tremendous advantage, and you know, it's reflective of structure. So the problem statements of how do we improve clinical workflows for the benefit of patients and clinicians is really driven by the fact that we have clinicians in key leadership roles. So, you know, supporting, for example, Dr. Gladman as our deputy CMIO is Dr. Victoria Chan, who's a respirologist, and she could clearly see the problem statement and the benefit. And I think that is a structural advantage that we have, where we have clinicians in key leadership roles. They do not relinquish their clinical accountabilities, but they obviously have dual roles, which always kind of vests our improvements around true problem statements, as opposed to the dangers of a CEO, for example, thinking they know where we need to go directionally to improve workflow and clinical workflow and clinical care.
Thank you for that. I have kind of a two-part question, so I'll talk with you. We learned, obviously, that even the best laid plans last year got turned on their head. And of course, you all, I think, were planning to open in February in a more traditional way, and instead open to actually help offset some of the capacity constraints of other facilities that were dealing with COVID-19 patients. And I'm curious, just, you know, what drove that decision? And like very practically, what did that mean? Like, what had you envisioned for your opening, and what did your opening actually end up looking like?
Yeah, so this is a decade-long effort, as Richard was describing, and everything was being measured at the end of the day around how successful we opened and how that first patient was cared for. So the operational readiness work was going in tandem with all of the construction and obviously the outfitting of the building in terms of all the equipment and the technology. And, we were well into the first and second wave as we continued to ensure that the builder could continue to complete construction, let alone getting all the equipment and technology. And what was interesting is so many of our vendors came from the US. I think Aviv and myself and Richard probably signed hundreds of letters ensuring that vendors could cross the border so that this facility could actually be delivered on time. That this was an essential service is sort of how we described it. Clearly the Canadian healthcare system and Ontario in particular, we've always been challenged from not having enough bedded capacity. So before the pandemic even arrived, the new government had campaigned on ending quote unquote hallway medicine, because we would have dozens of patients in every hospital waiting in a hallway in the emergency department for days on end to get access to a bed. So the pandemic only made that very real issue even more acute. And, when we started to deal with the waves, wave 1, wave 2, and in this case, we were sort of in between wave 2 and wave 3, there were some serious and alarming modeling data sets that started to suggest that as a province, we would get into a situation where we would actually have to ethically decide who received care and who didn't. And I think some jurisdictions in the US, like New York City, for example, kind of face similar challenges. Now, what was kind of unique and a little bit different than maybe the US system is that obviously we're a universal health care delivered model where as a public hospital, we have very defined legislation that defines how we deliver care and gives the government significant oversight around our operations. So what became very clear to the government is here we're opening a net new hospital. Yes, they want to open for their local community needs, but is there a way that we could repurpose it to deal with another problem statement, which was the Greater Toronto area, which we're located, being the hardest hit by COVID. And we did see a very asymmetrical situation in this province where, the north, the east, and even the west in wave 2s and to some extent wave 3 had very little COVID activity. It was really the large urban areas that got hit hard. So they asked us to open differently. So we in effect didn't turn on our emergency department, and our intake became exclusively receiving patients from other hospitals. So what was put in place some time ago, maybe in late December, was what is called the GTA, Greater Toronto Area Incident Management Structure, which basically moved patients from overoccupied hospitals with COVID to underoccupied. So our intake became exclusively through that structure. And over the course of about 2 months, we accepted 500 plus patients from other hospitals. So our emerge wasn't turned on, and then we repurposed a bunch of other functional areas. We didn't open our ORs as well. So our peri-op nurses, our ED nurses were redeployed to the ICUs to care for creating additional ICU capacity. So that's what we did. Very different opening than we would have anticipated. A lot of rework for our technology teams to ensure that the right kinds of equipment were available in different kinds of spaces. And in many ways, a bit more of a controlled opening, because when you open an emergency department, it does become a little bit more complicated. So the fact that every intake was from another hospital with very clear line of sight of the type of patient you're getting. But we then did care for the lion's share of COVID patients in the province through really the months of February, March, and April. And then as that third wave, which was our scariest wave by far, subsided, by May, we had made our decision mid-May to say, I think we're beyond this real challenging situation. So by mid-May, the senior team and the board made the decision to open completely on June the 6th. And that's what we've done. So as of June the 6th, the emergency department is open. Our maternal newborn program is running, our inpatient mental health, our regional stroke program, all these other services that were not turned on are now fully turned on. And we're happy that a decade of effort and a promise that was made to this community to add a second hospital has now been achieved.
Absolutely, and paid off in such an important way, quite candidly, during a really challenging time. Dr. Gladman, part two of that question is, in the United States, as just organizations started experimenting with hospital at home programs, hospitals without walls, sometimes technology enabled in the really integrated way that you all described, but sometimes really just playing around with new technologies. There's a real debate about which of those technologies, modalities, new processes will continue to exist in sort of a post-COVID world. I'm curious, when you think about some of the experimentation that you all did and some of the different ways that you may have leveraged technology during the pandemic, which of those things do you think are going to kind of carry over into net new operating systems?
Yeah, so we have been having internal discussions about that, because one of the questions that comes up is moving forward, how much do we want to focus in on some of those areas, right? So, for example, virtual care is an ongoing debate, because while it is certainly very convenient for people, there are certainly some types of visits that don't well fit the virtual care experience. And to be honest, I think that people overemphasize the role, for example, of video within virtual care. What we found was that most patients actually just wanted to have phone calls. And the reason is they may have been on the way to the grocery store or waiting in line somewhere when they were having their visit. And that created a great flexibility for them and a convenience. But if they had to have a video visit, then they had to be somewhere where they were, it was a closed environment where they could have that visit, and it was very different. And there were certainly times where they wanted that and times where they didn't. And I think part of that then was the acknowledgement that really is a continuum of care. We know that a lot of these technologies, certainly remote monitoring technology, will stay. I think we were quick to identify what the niche market is for those, and really it's those patients that that you do want to maintain in their home environment, but that do need that extra layer of monitoring. And for us, that's actually where a lot of the workflow automation came in too. So for example, we used intelligent automation rules to identify the at-risk patients, so that we weren't just leaving the flight controller, as it were, to manage all of these patients in flight all over the place, without calling attention to potential issues that were going to creep up, because it's just too much data now for any one person to really follow. So I think a lot of that technology will stay. I think that I don't think that we saw any technologies come out as a result of COVID that weren't already there, already happening. What really expanded was the pace. And what we're going to see, probably the biggest change we're going to see moving forward, are in, for example, mRNA technology, where they made huge advances. And what we will see come down the pipeline for medical management of other viral illnesses is going to be astounding. And so the technology itself, I think there's a much more adoption, or widespread adoption and acceptance of it, where there wasn't before. Certainly, if you, even without the healthcare piece, if you turn the clock back to before all this, we never would have thought that a webinar like this, that we would have had a meeting like this, a conference like this, is all a complete change in people's mentalities.
Yes, it's interesting what you said. We had a patient focus group at one point where we were talking about sort of patient preference in the different modalities. And one of the gentlemen participating said, it's one thing to have a virtual visit with a physician when I'm at home and only my wife is listening. It's a totally different consideration if I'm like back in my cubicle at work. And in that case, I might rather just go back to the doctor's office. So your point is really well taken around, sort of patient needs and preferences change also depending on the context that they are personally in.
And I think the other thing, people's expectations have certainly changed a lot. If you are not prepared to deep dive into your virtual care programs, even your experience in the hospital with technology, you're going to be left behind very quickly at this point.
Yes.
And Makia, if I could add to Dr. Gladman's comments, there are some negative unintended consequences of virtual care that really does speak to the outcomes of patients as well, which probably still early days we need to measure, but clear feedback from our emergentologists in our ED that they are seeing patients that are sicker, or ultimately things getting missed because it was a virtual visit. So, I think we're going to have to find some deeper protocols and appreciation of what is appropriate and what is not from a virtual care perspective. But we have seen negative outcomes in our ED because patients were not seen appropriately by their primary care physician in a virtual context.
Yeah, thank you for that. We've heard that also as we've talked to our colleagues across the country as well. Richard, turning to you. So even with the adjustment in your opening plans, it's clear that providing an enhanced patient experience has been top of mind for you and was one of the key drivers behind this project overall. What were some key sort of aha moments that helped drive home the importance of what technology's kind of potential impact could be on improving the relationship with a patient and the staff experience as well?
Wow, that's a extremely good question. And if I can, I actually want to go back a little bit of the history lane and go back to the beginning. And when we actually started to pilot or doing a little bit of a proof of concept, we actually established a unit in retrofit, very little capital investment. We actually retrofit a medical care unit in Richmond Hill. We call it innovation unit. And we put in RTLS, we put in lots of sensor, and we're connecting that with the nurse call system, along with some mobile technology that allow the communication from the nurse station, the nurse call system, the alarm bell, to the actual staff. And we also do it in a way that starting to inject some kind of like very primitive but effective automation and smart logic, where if a nurse who is actually taking care of those 3 patients, and when she's on break, it will automatically kind of like the system, you don't need to remember to pass my phone to somebody else like in the past. It actually automatically routed to another nurse in the area, and they will be able to kind of take up the call anywhere it is. And with about that less than a year of data, the aha moment for me is when we actually ask the patient who actually assigned to the innovation unit or versus the traditional medical unit just on the nearby area. They're real patient. We do it in live environment. One patient family that happens to be in that area, and I talked to her, and she actually is a returning patient to Richmond Hill. And she just kind of say she cannot explain it, but she was in the innovation unit and she finds that it's so comfortable, so calm. It's because of we get rid of all the noise of the busy call. Like when you have a unit of 32 patients, the nurse call is bipping all the way. But instead of that, we have the Doom light. We have the direct call to the cell phone that the nurses is carrying. So that environment is much more suitable and facilitated care and facilitated recovery. Kids can sleep better. And even the patient family visiting it find that the area, the unit is so much calmer. And she couldn't explain it. And I didn't tell them the secret between the difference between the two. But that's an aha moment that if you actually implement technology to address some real problem, that actually can improve experience and care outcome. The other side of the coin as well is we actually, in that same unit, again, RTLS in the entire area, I believe it's 2 floors that we injected in there, link it to the hand washing station, and we're able to collect millions of data points about the 4 moments, the 2 moments of hand washing. And when we started to, about a couple of months into it, we started to share aggregated data, and we see the nurses, well, the doctors group as well, and other care provider decided to have a little friendly competition who actually have the better hand hygiene, right? And instead of the good old way of observation that everyone believe they have 100% hand hygiene compliance, the reality is they're not, right? So it could also impact in a positive way if you do it correctly and engage the provider upfront and be transparent about it, building that culture of trust. You can actually also impact the provider's experience as well. So those are the two aha moments that we know we're on the right track.
That's really interesting. Dr. Gladman?
Oh yeah, I would just add on to that. We started this journey, the smart hospital journey, probably around a decade ago. And at that time, you couldn't ask anybody what a smart hospital was. And actually, I'm not sure that most people that are building similar facilities would be able to answer the question today. And when we talk about patient experience and provider experience as being a key component of that, we're still missing the what's the point part of it, which is I have a lot of these elevator conversations. Very rarely do people actually ask what a smart hospital is because they presume that they know that. But I would not say that until maybe a year or two ago, I would have been able to answer that question either. And the truth is that a smart hospital, what it is it is a facility that anticipates the needs of the patients and the healthcare providers, right? It creates these digital moments of engagement that empower patients, but also create an environment for improved quality and safety for the patients too. And when you frame things in that way, my aha moment was really just that. It's if we take a step back and we think not so much about, what is the best way to, to make things just more comfortable. They talk about the quadruple aim, right? We're really starting to think more in terms of how can we hit everything at once, right? How can you improve patient experience and provider experience, but also deliver those better clinical outcomes? And that is really where the use of a lot of these seminal technology comes in. And it's also why I continue to describe it as a journey, because we still don't know where we will go with all of the infrastructure that we've built here. I think that we're just touching the tip of the iceberg in terms of what's possible. And at the end of the day, our hope is that when patients experience these technologies or these, workflow automations, for lack of a better term, we'd like them to anthropomorphize a bit and see that bed, the smart bed or that bedside terminal, as a part of their, care delivery system, as members of the care team. And if they do that and they don't just see it as a computer, I think we've done a very good job.
I guess, just to build on those comments from Dr. Gladman, aside from the core business of delivering high quality, safe care, we think about that customer experience. I think we think about our own lives and our own customer experience in every facet of our life. Technology has given us a higher degree of control and autonomy. And ironically, healthcare is all about taking that away, right? So the whole medical model is actually built in a very militaristic manner to say, we will give orders, we will drive everything, and we'll let you know as an adjunct part of the process, as opposed to being core in that process. So let's even think, what have we done, with the Get Well solution and these tablets, so simple things like giving the patient control of the room, whether it's lighting, temperature, shades, simple things. In your own world, you can control those. We take all those things away. Ordering your meals, right? Again, a very archaic, old-fashioned approach. Now we give patients some control. Understanding their care plan and their care path and education material, let alone seeing their own electronic medical record. So all this stuff you have on your iPad at home, in the moment, we philosophically take away. And, this is a bit of a push too, because philosophically, as much as we have all this great technology, we still struggle. If you ask Dr. Gladman, what is his biggest push with our medical advisory committee, it's not having a delay in results being available to the patient. The clinicians would still like to have 24, 48 hours. They don't want those results to be available to the patient at the same time they see them. So fundamentally, we have to change our approach as leaders in healthcare to say, we can't empower consumerism with technology in one side and not put it, in the same space in a hospital. Like, I mean, as basic as it is, this is 5 years ago, we put in registration kiosks, and probably all hospitals in the US have the same thing you would have at the airport. Not rocket science, pretty basic. You have it in every other aspect of your life. So I think from the patient experience side, we're just catching up with really what exists in every other part of your lives, so to speak.
Yeah, that's such an interesting description, that technology has given us so much control over our lives, and then kind of when we're sick and feeling most out of control, a lot of that is in fact out of our hands and sometimes explicitly taken away. I'm curious if one of you could describe, we talked a lot about sort of the smart hospital. What do you see as being some of the key components of your new facility as you think about the technology you've put in, and ways in which it differs from your more traditional facility? I heard RTLS obviously being used really broadly, touchless registration. I'm curious other things.
Well, I mean, I think that the core building blocks really of the smart hospital, we tend to think of the technology in terms of sort of what are the things, the must-haves, right? And really, it's the stuff you'd expect in any high technology environment. You need very robust networking, both wired and wireless. You need really good unified communications. We talked about the real-time locating system. The locating system itself is only one part of a larger piece of a location-based service approach. And it's not even just a location-based service, it's really what we would more think about as an activity-based service. So a large part of workflow automation is actually, and that anticipation piece, is trying to figure out what someone is trying to do, at least on the provider side. But it's true also on the patient side as well, is if you want to augment the experience that they have, if you want to improve those outcomes, you kind of need to anticipate problems before they happen. And to do that, location is a very big piece of contextual awareness, which is with anticipation is the other part of this ambiently intelligent environment that we're building. So those are key, but actually, if you were to ask me what the single most important part of the secret sauce was, I would actually say it's the people inside the building, because technology is only one part of the smart hospital. The building a workforce or enabling a workforce that's actually capable of responding and to all of these things that are going on, and actually apply the technology to deliver better care and not set up barriers, which is probably the biggest thing we see in other places where the physicians or the nurses are ready to just say no. We're getting very big privacy issues when you talk about location monitoring, when you talk about task recognition. There are lots of reports of obstinance to these issues with unions, et cetera. And these are all areas that we approached head on before we actually ever got into the construction of anything. And so, if you want to get into that, we can also talk about the nitty-gritty of the technology itself. But when I talk about the unified communications, that's not just on the provider side. You need that on the patient side as well. We chose to go, as you know, with the GetWell bedside the infotainment system, because it really is a one-stop shop for the patients. And again, the hope is to have that seen not so much as a tool for the patient at the bedside, but as a component of their healthcare environment, so that they see that as part of the team, right? Because that's how they communicate with their nurses. That's how they establish that they're having pain, so that the nurses know that they need to do something about it. It's how they request their food. It's how they interact with the environment, turn the lights on and off. And that concept of not only are we giving them that sort of environment, but we're also able to monitor that environment and then make decisions that anticipate, the issues down the road. So for example, when a patient is, their pain scale is rising, we can track this information. We can track the times that it takes before we deliver pain medication. We can anticipate when the next request is going to come and just be a little bit faster the next time.
So interesting, your comment on the people side of this. We work with another organization that leveraged the Get Well technology in the context of actually a really big smart facility. And that was one of the things they said, that if they could go back in time and sort of do it all over again, they would have actually focused on a lot of service training for their staff, because technology sped up so many things that their staff was actually used to having a lot more time to deal with, and gave patients the ability to like interact more quickly. So that point's really well taken. And I do want to come back to, towards the end of this call, just lessons learned and things that you did and would do again, and things that you might do differently the second time around. But before we get there, so you're now open as a full, true community hospital. And I'm curious, Altaf, what are you most excited about as you think about sort of serving your community in the way kind of the facility was intended to operate?
So, you know, I think fundamentally it's all driven by access to care. So this is a community, the city of Vaughan itself, you know, a community of 350,000 plus residents, has never had a hospital. So, you know, they can actually call this their own, and it'll be driven by very basic services, from our emergency department to our birthing services to our mental health program. So it is meeting their expectations first and foremost. The technology is a nice to have, but at the end of the day, it is access to the top-notch clinicians that we recruited, really the ability to deliver care in that very, very human way, and fundamentally try to live up to the promise of improving access, which is really driven by reduction in wait times and, you know, just faster access to care, whether it's the wait and emerge or how quickly you get to a bed, which is not completely within our control, as you can imagine, because it's really driven by funding and really driven by our most challenging piece, as you heard about, which is people. And as probably most jurisdictions, HHR is health human resources is by far the most precious commodity we have right now. We even call it a commodity. It's a very special, you know, piece of the pie that's just not there. We are seeing a huge amount of burnout, people leaving the profession, just tired of being on the front lines. And you know, COVID has taken a massive impact on people's well-being. I don't think we're going to really see it until the next few months, when we start to decompress and you know, go back to some form of a normal life, and then realize, oh my God, I can't believe what we went through for the last 18 months, right? That's going to be the challenge. So I'm just really proud that we're able to deliver on that proposition of improving access to care. You know, the next piece is truly starting to demonstrate the evaluation of the smart hospital. So there isn't, you know, as Aviv was discussing, there isn't a designation saying you're a smart hospital. But I do believe that we'll be able to show with evidence the impact of smart workflows. You heard Richard, for example, describing hand hygiene, which is the most basic dimension of preventing infections and outbreaks. So our ability to start to measure and demonstrate to our funders and to the public that you know, the investment that we've made in all of these tools and technologies actually has a benefit. We don't take enough time to evaluate, and I think that's some of the work that we'll start to turn our attention to. But again, just very proud that we've doubled the access to this community that has been most challenged to receive care. It's the first, just to put things into perspective, the first net new hospital to be built in the province of Ontario in 30 years. So we have not added a lot of hospital capacity in this province. The prevailing view of previous governments was to shift care into the community, and that does work. There's no two ways about it, but we need to keep up with acute care beds, and we are, as a jurisdiction, the most underbedded sovereign sort of state in the entire world right now. So we need to build a few more hospitals, in my view.
Right. I'm going to go to lessons learned, and Richard, I'm going to start with you. So as you think about sort of your journey over the last decade, which accelerated over these last couple of years, as you look back on the various elements of planning, technology selection, testing, et cetera, what are some things you feel like are true best practice that you all did well? And what are some lessons you'd share of things you might approach in a different way the next time you embark on this, or as you continue to evolve?
Yeah, there's a lot. But if I have to pick one, I think what we did right in terms of the approach, and I would encourage all other hospitals to follow, is like really start with the people including patient, family, and provider upfront, and resist the temptations to get onto a project before you actually engage all those critical people who are in the center of everything that you're building. And that would be really important. The second one that I really kind of find that we did quite well, and it's going to be building a good foundation for us going forward, is we think of all the, I like cooking analogy, those who know me. I would rather have all the ingredients ready in the kitchen cabinets, even though I don't have a complete well-written recipe that what I'm going to cook, so that I actually can give the flexibility and provide the flexibility for all the problems that may come our way, including pandemic that we never expected, and we're able to react and be agile about it. We all wanted to have high reliability healthcare services, but the high reliability healthcare services need to mean that non-interrupted platform and system to support the nurses. The worst things you can do in terms of technology investment is you put on something into that, introduce it, and it's kind of like the favor of the month, and then that thing breaks, you'll never get adoption, and the perceived benefit that is supposed to return to patient or provider will never be gained. So we have a robust infrastructure, and we actually have quite clear process to identify whatever events that we want to make sure that happen 100% of the time. We also want to make sure that, to use technology to improve outcome. We also want to use technology to help to elevate or to mitigate those never events, so that you don't have to rely on human memory. You don't have to rely on passing on the notes in a linear way. You can actually do those smart events that actually what NASA and other people have perfected in other industry. Healthcare is catching up on that. So I think if we want to do it like the next 2.0 of smart hospital, we probably need to learn from other industry to do that better.
Really interesting. Dr. Gladman, Altaf, anything you'd add?
The one thing I would add actually is I knew at the outset that there was always going to be the need to make a business case at the end of the day for every new technology. And I was taught well by Richard and Altaf. At the end of the day, there's still dollar signs attached to things. And as much as we'd like to think that healthcare can be completely separated from that, it really can't. I mean, that's the situation. I think that before we went into this, we knew that there would be business cases to justify the cost of the technology, but we weren't really sure how significant they would be, both in terms of clinical and business outcome improvements. And, I have to say that for me, a big lesson learned was when we look back, for example, over that COVID clinic, that virtual clinic, that even I knew I had the faith, but I wouldn't have believed that that one clinic that we threw together probably over less than a month period, using technology that we had available at the time, that would result in more than 850 prevented hospital admissions, or that it would save the system more than $8 million. So lesson learned there is if you need to have faith in your approach, because that was the short planning period. I'm very excited to see what's going to happen when we actually sit down and leverage things not under the gun and actually rebuild the process from front to finish, and look at what that looks like both to our patients and to our providers, but also to the financial bottom line too.
Thank you. That's really insightful.
And what I would advocate is, and maybe I'll put a challenge to your audience here as well. So from my perspective, it is all about sort of our staff and change management, and their ability to understand and appreciate the merits of whatever we're doing and how it'll benefit their care delivery, their day-to-day lives, and ultimately impact patient care. And what I'm always amazed at is how, in many ways, the vendor community's reputation and success is very much based on the partnership of the organization they're going to ultimately sell and deploy their technology at. And I would say more vendors need to do their own culture and readiness assessment of organizations. And in many ways, it could be a quid pro quo saying, you know what, as much as you want to buy our product, we don't want to sell our product to you because we don't think you're going to be successful, because we don't think you have the change management, the human factor side of this to be actually successful. I've been amazed, and we've been watching various implementations of the products that we've put in our own hospital and watch disastrous implementations. And we go back, and our own assessment as Mackenzie Health is they didn't understand the human side of the change management piece and all of that early readiness side that actually has to occur, or they've had bad implementations in the past, so there's not a lot of good faith from the staff side to actually take a chance, right? So all those things have to be vetted, and I think we were very proactive in understanding the implications of how much our staff could absorb. And we did conscious things. So we deployed the EMR 5 years before Cortellucci Vaughan came online, because we said we can't do a new EMR and a brand new hospital at the same time. Too much change, too much disruption, too much risk, right? So that human side has to be assessed, and you need to look at whether it's culture surveys or readiness surveys. Just because it was successful in one facility doesn't mean your organization can pull it off, or maybe if it wasn't successful, you could still pull it off based on the culture of your organization.
Thank you. One question that came in through the question bar was just a request for some information on kind of how you chose Get Well Network to partner with you for part of this project. And I will note to the audience, the Mackenzie Health team was a really good innovation partner to us as well. I think really pushing us to also develop our technology in ways that served their communities better, that weren't on our roadmap when we first sort of signed up to partner. Things like developing, using telephones over iPads, certain elements of signage, et cetera. So I think the rising tide sort of lifts all boats, and our partnership with you, I think, has also improved the service that we can deliver. I'm curious kind of how you all selected us as a partner, and also like what conversations you had. You talk a lot about like talking to the clinicians, talking to the patients, but Altaf, you just injected as well, like talking to the vendors themselves. And I'm curious how you approached the selection of Get Well audience question, but also sort of thinking about that sort of interplay of vendors as part of the larger project. Richard, I'm going to turn that to you to start.
Sure. Let me start, because I'm the fully disclosed. I'm the one who actually pushed Get Well quite a bit, and I apologize for that. But I can tell you that Mackenzie will continue to do that for the benefit of both organizations as well as all the patient and family. We started with a very traditional RFP, and the RFP is really to replace our infotainment system. But the infotainment system that we have in Richmond Hill in the past is really just nothing more than TV and movie and all that. But the timing is just around at the same time that if we actually are planning for the Cortellucci Vaughan Hospital design and all that, we actually started to think, do we just still using a infotainment system as a solution that will become the positive distraction for patient, knowing that in your private life, in our own private life, no one, how many of us still have landline at home? Altaf may still have it. And how many of us still kind of like subscribing to TV packages that you only watch 2 of them, but the 14 others you pay for nothing? People bring their iPad in, even at Richmond Hill back then. People use their cell phone to connect to them. So we kind of thinking that we are still trying to expect to achieve patient satisfaction by giving them something that is of history of the past. So we started to think about what to do. And we then started to kind of learn from other hospitals globally and change our RFP direction significantly into more like a engagement platform. We injected a lot more criteria and outcome that we want, which we actually don't know who can provide it. But we actually, using this term, we kind of take a leap of faith and then tender it in such a way that including all those additional requirements, and the CO comes in, and we didn't even actually specify how the vendor would be is needed to provide that. We just say we want this as an outcome. It's an outcome-based procurement that we started to do. And surprise to us that we actually have 3 or 4 people, very different approach that coming responding to the RFP. And through the evaluation process, talking to the team, we quickly identify the uniqueness that's standing out from GetWell platform is the focus on clinical, the focus on patient experience rather than actually the entertainment side of the house. So that's really where differentiated. They all have their business side in terms of the cost implementation. But one thing that I really think that we find the right partner, not just on the attitude or collaboration, but also the flexibility, right? As what you're saying, we're able to add tile quickly for a phone call. There's a couple of other projects is coming down the pipeline as well to continue to add more component to the same platform, giving that agile platform to grow and very much consistent with Mackenzie Health visions of smart hospital that will continue to evolve with us. So that's true partnership.
Excellent. Thank you. We only have a couple minutes left, and so I'm going to end with you. What is next for Mackenzie Health? So when you think about sort of the next 5 years, ambitions for the hospital, maybe for building a couple more facilities, I'm curious, kind of what do you see coming down the pike for you all?
So, I think it's more driven by a massive gap in our system, which is the hard silos that exist between the various component parts of the healthcare system. So we have terrible silos between long-term care, between primary care, between acute care. And our vision, which we've already started, is to start to use technology to drive the integration. So we have unfortunate things like governance and independent or sort of structures that get in the way of not being patient focused. So it is very hard to navigate our system because it's not really driven from the patient's perspective. It's really driven by provider views, whether it's our market share funding, independence. So we're going to break that down with technology. And I think, the ARC clinic that Aviv talked about was, a very quick example. We implemented it very, very quickly, and the outcome benefit it had and the support we had from primary care and specialists in the community was very, very strong. So our next effort will be how do we take what we've done in the hospital and sort of drive its application into the community, whether it's primary care, long-term care, subacute care. That's our next effort.
Well, thank you all so much. I tried to weave some of the questions that were coming in throughout the conversation. So thank you very much to our panelists for your partnership and also for spending time with us today. We hope to profile you again in 6 to 9 months as you have a chance to really get kind of your sea legs in the smart hospital and to talk about some of the work that you do over the coming months. So thank you so much. Thank you so much to attendees as well. And there's some contact information for those of you on the phone that will be in the materials we send out. If you have additional questions for GetWell Network or for the Mackenzie team, please feel free to email them and we'll make sure that we get back to you. Thank you so much, everybody.